Hello, dear colleagues. Welcome to this author interview. I am Bashar Qumseya, the chair of the Standards of Practice Committee at the ASGE, and I'm glad to be joined today by our colleague and first author on this guideline, Nayantara Coelho. She's at the Mayo Clinic, and Naina led the development of this guideline, and she will be discussing with us today how this guideline was developed and the most important items included in this guideline. This guideline discusses one of the most commonly done procedures, which is upper endoscopy or EGD, and it is titled Adverse Events Associated with EGD and EGD-related Techniques. All of us started our GI training by performing EGD, and we're all familiar with it. More recently, we can do more and more things with upper endoscopy, and it used to be initially only diagnostic, but now we can do a lot of things through an upper scope. And the goal of this document was to inform you of the rates of adverse events and also possible predictors of adverse events, so you can educate your patients about it and try to avoid adverse events. In this guideline, we performed a systematic review, as we do always with all of our ASGE guidelines, of all the available literature, and tried to identify studies that had meta-analyses and systematic reviews, or prospective data, then retrospective data, and then case series. And we will try to present this data to you the best we can. Naina, welcome to this author interview, and thank you so much for your work on this guideline.
Thank you, Bashar, for the opportunity. It's been a pleasure.
All right, Naina, I know you just today you stayed up all night doing an upper endoscopy for a patient with a variceal bleed. So this is fresh on your mind, this topic. I guess in this document, we tried to summarize our data in table 1. So can you tell us more about this table 1, which is the most important in this guideline?
Sure. So what we decided to do in order to make this document flow easily was we decided to divide the various procedures first. And so we looked at EGD as a diagnostic procedure with just biopsies or without biopsies. Then we looked at EGD with management of foreign body impactions, EGD with dilation, including the various parts of the upper GI anatomy, EGD with stent placement, hemostasis during EGD was looked at, but we didn't include any details about newer technology simply because some of that data is not available. And lastly, we looked at EGD with placement of either percutaneous gastrostomy or jejunostomy tubes and summarized the data for this. For each of these procedures, we then looked at complications which are the most common, including bleeding, perforation, risk of any infection, including cardiopulmonary infections, and then other cardiopulmonary or hemodynamic instability issues per procedure. And we then examined the risk factors that we found in the literature for each of these adverse events. And all of this data is summarized in table 1.
Excellent. Thank you, Naina. Yeah, I agree with you. I think this table 1 is very helpful because if you're doing an endoscopy and you just want to say, okay, what are the possible risk factors, you can just go to it. And the reason, as you said, the reason we decided to separate this is we know that doing a diagnostic EGD with maybe just biopsies, it has different risk factors than placing an esophageal stent or for hemostasis or PEG placement. And that's why we chose some of the most common categories as you just detailed. Excellent. So without going into further details about this, let's just go through some of these endoscopic procedures and discuss some of the possible adverse events, their rates, and most importantly, try to focus also on some of the risk factors. So starting with a diagnostic upper endoscopy. What's a diagnostic upper endoscopy, and what can you tell us about its adverse events?
So diagnostic upper endoscopy, even including biopsies, is very, very safe. The risk of bleeding, even while on anticoagulation, we found was less than 0.1%. The same for the risk of perforation. The infections were mostly related to aspiration pneumonias, but were still very rare at 0.3%. And I think part of this is because of better patient selection, as well as increased use of prophylactic intubation if necessary, and the fact that these are diagnostic, and so in general, patients are healthier. But the biggest risk factor we found for almost all the complications was an older age. And so the risk of bleeding was higher if you were over 65, and the risk of infection was higher if you were, in general, a sicker patient. So if you had had a preceding hospitalization or the need for multiple procedures, that was a risk factor. Interestingly, a lower facility procedure volume was found in one study to be related to increased risk of infection. This could be related to the availability of anesthesia resources, et cetera, in case better airway protection is required. The biggest risks that we saw overall were really cardiopulmonary, including hypotension or bradycardia. And these were still very rare at less than 0.1%, but of all of these complications was potentially the most common. And again, the highest risk factors were an older age, being obese, having hypertension, diabetes, so in general, sicker patients.
Excellent, excellent. So I think it's safe to say, put it in another word, the overall risk of adverse events is 1 in 1,000 to 1 in 10,000 overall, right? So very safe, as you said, and patients obviously naturally who are sicker to start with, have older age, diabetes, coronary artery disease, are more prone to having adverse events, but still, they are still very uncommon. Excellent. All right, and what about the management of foreign body or food impaction? You know, this is not something we look forward to doing in endoscopy. I can speak for myself. Usually we get a late night call in the middle of the night and the patient, you know, had a food impaction or sometimes a foreign body, and we have to go in and take care of it. So what can you tell us about that?
So this had a higher rate of complications, this procedure with management of foreign body compared to diagnostic, obviously. The highest risk really was that of aspiration pneumonia, and the range of risks there was anywhere from 1.8% to 6%. This is likely due to, you know, varying availability of general anesthesia and intubation for these procedures, but ideally that should be performed. The other risk factor, was that of perforation. And multiple studies, including meta-analyses, showed that the risk of perforation does increase with a longer duration from the time of impaction to the time of disimpaction. So the longer the foreign body has remained in position, the higher the risk of perforation during the procedure. The risk of bleeding was only 2.6%, and the only risk factor was really the use of a cap, but this data was not very robust, and so even it was significant and it is mentioned, but really the risk of perforation is the other major risk. Also depends on the size of the foreign body in place and if there was a bone fragment, and that was another risk factor for perforation.
Excellent. Yeah, I agree with you. So clearly, as we started with the diagnostic EGD with very low risks here, the adverse events rates are becoming, you know, in the single digits, up to 6%, for example, the aspiration pneumonia, which is obviously significantly higher than the rates of 0.1 or 0.01%. So management of foreign body or food impaction definitely carries some risks. And as you said, perforation probably is one of the main ones. Now, we kind of stayed away in this document from recommending, because this document is not really about how to do things, but on the rates of adverse events. We kind of stayed away from what time or period should you go in and do the food, take care of the food impaction. But it's generally safe to say that the sooner, the better, as soon as you're aware of the food impaction. The sooner you can get to it, the better off the patient can be to mitigate the risk of perforation, as we mentioned, that the time period between the onset of the symptoms and presentation or endoscopic intervention is one of the predictors of perforations. Would you agree?
Correct.
Correct, ma'am?
Yeah.
Yeah, okay. All right. Also, we noted, interestingly, as you saw in some of the data, that using an overtube can increase the risk of perforation. What can you tell us about that?
So this is not very robust data, but the idea is that if the overtube, again, if the main site of perforation was actually in the hypopharynx and in the upper esophagus, or the cricopharyngeal area. And part of that could be, just from the tube, the insertion technique, especially if you're not have significant familiarity with passage of the overtube, that could be a cause. But even that was quite rare. It wasn't very commonly reported in the data.
Yeah, I agree with you. I mean, I think anecdotally, people who use overtubes can probably attest to that. I can tell you, in a recent case that I had, we had performed a gastrojejunostomy, US guided, and wanted to suture the stent in place, which is debatable whether you should suture it or not. And when we place the overtube, and I do a lot of overtubes, because I do a lot of ESG here, we noticed a tear in the upper esophagus. It was not full thickness, but it was humbling to see that definitely, passing those overtubes is not risk-free. Excellent. Okay, so management of foreign body, food impaction. What about stent with dilation? I think we do a lot of dilations here. Many people do perform them regularly, excuse me, for various indication, benign and malignant. So what can you tell us about EGD with dilation?
So what we did was we looked at the various sites of EGD of dilation. So whether we did it in the esophagus, and we divided that into esophagus, gastroduodenal, and post-surgical, because these are more and more common more recently. And so looking at esophageal dilation, really the biggest risk factor, the biggest risk was obviously the risk of bleeding. It was still not very common. And I apologize, it was actually the risk, both bleeding and perforation, up to 0.7% of perforation in the esophagus. And we'll talk about the risk factors for that. The infections and cardiopulmonary side effects were really not reported in the literature, and so we didn't mention these. When you talk about bleeding, really the biggest risk factor was, there were multiple, but the biggest one was dilation of caustic strictures and dilation of malignant strictures. And those were the biggest risk factors for bleeding. There were also significant risk factors for perforation. Another risk factor for perforation was the head and neck radiation and head and neck cancers. And again, corrosive strictures, which had a perforation risk in some literature up to 30%. And so that was quite significant. Having a smaller starting diameter was found to be significant for a risk of perforation, the initial diameter of the stricture. What was not found to be any different was the use of either a balloon versus a bougie for dilation. So that was found to have no difference in the literature. And again, male sex and older age were risk factors for perforation, but that could be confounding with the underlying disease, which is also with Barrett's esophagus. And the other risk factor for esophageal perforation was a pneumatic dilation. And so a pneumatic dilation, but there was significant data to show that if you started with a 30 millimeter balloon, you had less risk of perforation than the initial dilation being with a 35 millimeter balloon. So that's an important clinical point, I think, to remember.
Yeah.
So then we looked at gastroduodenal dilation and what those risk factors could be. And that actually is significantly higher risk of both complications. So bleeding particularly was up to 7% in some literature, and perforation 1.5 to 1.8%. But again, this is, this is very variable data. And so it's hard to know. The 7% potentially could have been an outlier. It was in a single center analysis that high rate was found. Most of these patients were patients with Crohn's disease. And the meta-analysis of a large number of data showed about a 2% bleeding risk in this population. Perforation again was associated with the smaller initial diameter and dilating further. And then post-surgical stricture dilation really was, we looked at both Roux-en-Y gastrojejunostomy strictures as well as strictures after a sleeve gastrectomy. And these were significantly lower in terms of risk of both bleeding and perforation.
Excellent summary. I mean, obviously, this is a complicated subject. You can dilate the esophagus, as you said, gastroduodenal, a lot of times maybe the pylorus or duodenal strictures, and of course, as you said, post-surgical. When you dilate, most commonly we're not using pneumatic dilation, except a lot of times in achalasia we might still use that. So that has a little bit higher risk, but still, like you said, low risk at 5%, but certainly it's much higher than, for example, a diagnostic EGD. So, what do you have any practical input on when you do dilation? You go in, you find the lumen, it's small. And I always tell the fellows personally, be more conservative and live to fight another day. So, you dilate a little bit. Don't have to be too aggressive at the first go around. These strictures, especially the esophageal, are often difficult to deal with, and especially if they are they start at a small diameter, they are going to require more than one session. So what we do is we bring the patient after ESD or EMR. We'll bring the patients every 1 to 2 weeks and dilate them a little bit at a time. Until we kind of get them to where they are basically asymptomatic. But do you have any suggestions to?
So I think it's always important to know what the underlying etiology is, because I think you can be a little bit more aggressive when there are certain etiologies. For example, if it's a esophagogastric anastomosis, that might give you a little bit more leeway, or even a Crohn's stricture might have a little bit more leeway. But a patient who's had an ESD, or a patient with untreated eosinophilic esophagitis or a corrosive stricture, all of those are going to have a higher risk of excessive complications if you go too far. I do try to teach the fellows to have an estimation of original size and potentially go by the rule of 3, but really you should always re-examine the mucosa. And if you've gone 3 sizes up and there's no mucosal trauma at all, you can gently go up another size and reassess, especially when you're using bougie dilators, because I think sometimes the tendency is, because your scope is out, that you may not want to keep going back in, and you should. You should re-examine, especially after you've gone past maybe 3 sizes beyond where you started.
Okay, so re-examination obviously is key if you're using bougie dilators. I agree with you. Excellent. So again, this is a commonly performed procedure. One thing I also like to tell our trainees as well is to go by the patient's symptoms and not by the endoscopic findings. So I noticed that some patients may have a benign stricture, but they report that they can eat normally. Maybe they chew their food well and stuff. I don't try to dilate them very much if that is the case, if at all. So if a patient's symptoms are minimal or they are asymptomatic, you don't have to go after these strictures, assuming they're benign, because there are obviously risks of perforation and bleeding and things like that. Okay. Excellent. The next topic we have is endoscopy with stent placement, esophageal stent, and again, gastroduodenal stent. So you want to tell us about that?
Sure. So again, we looked at these separately, and in the esophagus, there was a significant risk of bleeding. Now, these were mostly uncovered stent placements, up to 3.7%, and perforation was lower at 0.9 to 1.2% for perforation in the esophagus. The risk of aspiration pneumonia was as high as 2.5%, but again, this is most likely because of obstruction at the site that the stent is being placed for, and therefore an increased risk of aspiration pneumonia. One of the other factors we examined was migration of stents, because that is an important outcome, as well as stent occlusion. And predictably, we found that migration occurred when covered stents were placed, especially in the esophagus, as well as when they were placed for benign disease. There wasn't significant data on stent fixation, and so that is, that factor obviously plays in, but that was not in the reported data. And stent occlusion, the highest risk factor was when you had uncovered stents placed, as would be expected, especially in a malignant situation. For gastroduodenal stents, it was about the same. Bleeding was a little bit lower at 1.5%, but these were, again, mostly malignant strictures, not so much benign, and perforation too was quite low.
Excellent. I agree with you. We also have a guideline which we published in 2019 about the management of gastric outlet obstruction, in which we specifically discuss those issues. Basically, with an uncovered stent, it's less likely to migrate, but it's more likely to get occluded, whereas in a covered stent, especially for malignant gastric outlet obstruction, we don't have FDA-approved covered stents to be used for that indication. But they do exist elsewhere. But they do tend to migrate. Some would argue, and we've argued this before in this committee, that maybe dealing with stent migration, especially in the small intestines, is more difficult than dealing with a stent occlusion. With stent occlusion, maybe you can dilate again, stent again. Whereas if it migrates into the jejunum or further down in the duodenum, sometimes it could be difficult to get back proximal to that area. So I think those are important considerations when you're doing stenting. You do mention the rate of aspiration pneumonia here on the guidelines, but in up to 2.5%. I think especially in patients who have esophageal stents where that bridge the lower esophageal sphincter, now you essentially don't have a lower esophageal sphincter function. So this can happen. We didn't comment on this a lot, but there are some stents that have anti-migration properties that can be placed endoscopically, and there's a mixed data on that.
They're not available in the US, and so that was one of the we didn't include that. The other risk is gastroduodenal obstruction and a dilated stomach, and the importance to always protect the airway for those patients.
Now, also important to note, Naina, that this is here we're talking about stent placement by endoscopy, not by EUS, right? Because we had a separate document, which you were a part of as well, in which, of course, for example, we're talking about gastric outlet obstruction. As I just mentioned, you can do stent placement, aluminum-opposing metal stent placement to create a GJ and get, relieve the gastric outlet obstruction. This is becoming more common, but this is an EUS guided technique. So we do discuss that in our EUS guided and EUS techniques and adverse events associated with EUS, which was also recently published. So I refer our colleagues to that. Okay, two more procedures to discuss briefly here. This next one is hemostasis or prophylaxis of bleeding. Certainly, we're doing more and more techniques to control bleeding, as you were just involved in one this morning with helping a patient with the variceal bleed. So what can you tell us about those, the risk of these procedures?
So even though this might be one of the most common procedures we perform, there actually isn't a lot of randomized trials, obviously, comparing different mechanisms here, and the data is actually quite limited. There is a fair amount of data in the variceal literature, but it's always comparing this to non-endoscopic methodology. And so really the highest risk of bleeding was reported at 1.4%, and that was with glue injection into varices. Again, aspiration pneumonia was associated with variceal balloon tamponade and reported to be up to 11.2%. But of course, that's hard because the patient is usually actively vomiting at the same time. And so there could be multiple etiologies, but that's a very high risk of aspiration pneumonia in these patients who are overall very ill. And interestingly, there were a lot of other complications noted with this. So fever was noticed again with injection of glue into varices, reported at 35% in one study. Stent placement for variceal bleed was associated with migration as expected because this is a benign disease. And then with band ligation, dysphagia or chest pain, this is up to from 6 to 23%. Usually transient, very easily managed, but definitely something to keep in mind as you decide what you want to treat your patient with. And again, because the literature is not great in this whole subsection, we were not really able to identify any specific risk factors for these particular adverse events.
Excellent. I agree with you on this chest pain and dysphagia. It's important, especially I think if you're doing it for prophylaxis for varices, because the patients come in for screening and you band them, and maybe you haven't discussed this risk with them very much, and then they wake up. I've had some patients wake up with a lot of pain. Mm-hmm. As you said, usually it's transient and goes away, but it's important to have this discussion. And that's the point of this guideline, is to inform physicians so that they can know how to kind of try to avoid them, but also to have the discussion with the patients. That most patients don't have chest pain or dysphagia, but you can have it, especially if you, I think, there's no data on this, but I think anecdotally, if you place a lot of banding, if you put 6 or 7, it's probably more likely to happen than if you put 1 or 2, and if you have larger varices.
And an important thing to note here, Bashar, is because it's transient, patients don't usually require narcotics for this. You can just manage with topical anesthetics, and patients do really well within 12 hours.
Excellent, excellent. All right, last but not least, let's talk about PEG placement or percutaneous endoscopic jejunostomy. In many practices now, I see that IR, for example, does a lot of PEG placement, but it depends on the practice, and we still do quite a good number of PEG placement here. So it's important to understand it's got its own risks and adverse events that we need to discuss. So what can you tell us about that?
I agree. I mean, I think we do perform a very large number of these procedures here. And the biggest risk is really the risk of causing bleeding. And a lot of this is associated with the risk factors that have been shown in the literature are being obese and having diabetes. And I think part of that is that in these patients, especially obese patients, it's hard to identify the vasculature during transillumination, and you might be more likely to go through one of the subcutaneous vessels. So bleeding has been reported to be up to 2.4% for PEGs, a little lower, up to, about the same, 2.6% for PEGs, 2.4% for PEGs. Perforation, obviously, you're creating a perforation. I think what they're talking about here is whether you perforate a different organ, such as a transposing colon or something in between. And this is quite rare, I think, especially as we improve techniques with transillumination and safe track method, this is much less likely. And then the other risk is that of site infections, which have been used to be more common, but now with prophylactic antibiotics given at the time of the placement of the tube are significantly lower. So that too is only 1.7 to 3.4%. And I think aspiration pneumonia is related to patients who have a gastric outlet obstruction and are getting venting pegs placed. That's the literature. And fever has been noted up to 3.5%. And I think this is important to remember because you might have a transient fever. Most of these, again, are not from are from data that is a little bit older. So with prophylactic a single dose of antibiotic given intraprocedurally, this is lower because there was no significant infection noted in these patients.
Excellent summary, Naina. I think to summarize some of what we have said, if I may, is a diagnostic EGD, which is one of the most commonly performed procedures, appears very safe, where the risk of adverse events in the 1 to 1,000 to 1 to 10,000 range, which is very, very safe. However, once you move into doing actually endoscopic interventions, as we have said, management of foreign body impaction, dilations, stent placement, treating of bleeding or placement of bag, those risk factors do increase significantly. They're still very uncommon, but depending on your perspective, 2% to 3% is still a significant number of adverse events. So the goal of this guideline is to make you aware of these potential adverse events and raise awareness, and also to look at some of the possible predictors and trying to predict some of these adverse events ahead of time, and of course trying to manage them early if they do happen. I mean, I think if you perform endoscopy, adverse events are part of what we do. But there are things that we can do to understand those risk factors and to try to maybe mitigate these risk factors. And most importantly, to have a discussion with the patient and the family about those risk factors as part of the informed consent process. We have a separate document from the ASGE and Standards of Practice Committee on informed consent and the best practices to do informed consent. So these documents that we have now, we have an adverse event document on this upper endoscopy, which we presented today. We had one on endoscopic ultrasound, which we presented a few months ago. And we also have one on colonoscopy, which was done a few years ago. So our goal again is to try to educate all of our colleagues on how these, what these rates are, and potentially how they can be mitigated, recognized early if they do happen, and also trying everything we can to avoid adverse events. Thank you, Naina, so much for working on this document. I really enjoyed it. I think it's a very important guideline and document. It's a bit different because in this document, we didn't provide any recommendations, which is kind of what we normally do. But still, it's an important review of these adverse events. And thank you so much for doing this. I do want to thank the GIE for allowing us to do these author interviews for our guidelines as we try to get more awareness of our guideline process. If you have any questions about our guidelines, please feel free to email the ASGE at info@asge.org or email me directly as well. I'm happy to answer. Our guidelines do undergo a rigorous process, and we also submit our guidelines for public review. An email just came out about a public review for our guidelines, our most recent guidelines. So if you do get an email from us about reviewing these guidelines, please do review them, and we take your feedback very seriously. Thank you all so much. And again, thank you, Naina, and I look forward for future guideline interviews. Thank you so much.
Thank you.
Lauren?